Welcome to the touchIME. So I'm Ken Kato from National Cancer Center Hospital. I'm a medical oncologist for the upper GI cancers. I'm joined today by Ms. Tara Hurley, an oncology nurse at the Royal Marsden NIS Foundation Trust in Sutton, UK. In this section, we will consider current and upcoming indications for immune checkpoint inhibitors in solid tumors and general consideration for their use. Here is a treatment landscape for the solid tumors approved for the FDA by the FDA and EMI and PMDA. So we have many immune checkpoint inhibitors. The target of the PD-1 and PD-L1 and CTLA-4. For the many indications for the various cancer types right now, we use these drugs not only for the metastasis cases, but for the recently the indication of the ICIs was expanded to the local cases. For example, the neoadjuvant chemo or immunotherapy for the lung cancer, and the adjuvant use for the melanoma and the renal cell carcinoma. And many of the phase 3 studies that's upcoming, the combination with another immune checkpoint inhibitors, such as TIGIT antibody and LAG-3 antibody right now. So in combination with radiotherapy with immune checkpoint inhibitor is also developed for some cancer types. Okay, so the indication of the immune checkpoint inhibitor will be expanded more and more, and we expect the increasing of the efficacy with immune checkpoint inhibitors. Okay, so Tara, so do you use the immune checkpoint inhibitors for the patient? So how do you consider about the indication for the immune checkpoint inhibitors for each patient?
So my background's in clinical trials, and I've primarily specialised in breast cancer, head and neck cancer, and non-small cell lung cancer. And within that, obviously, within clinical trials, you have a remit of specific patients that you're due to treat. However, our main criterion just generally, and now that it's moved out, a lot of the treatments have moved out of trial, is to consider their performance status, just assessing options for whether they've got what their PD-L1 status is. So we would send their tissue material off to the laboratory, and if they have a PD-L1 score of above 1, we would consider them for immune checkpoint inhibitor therapy. The higher the score, generally it is seen that they'll have a better response to treatment. So we're very honest with patients about that. If they had a score of less than 1, that we wouldn't attempt to start them. And then we would also just review their comorbidities and any other medications that they may be on, in line with giving them the best and opportunistic opportunity for commencing the therapy.
So how do you use for the patient with the lower performance status? So do you eliminate the use of the immune checkpoint inhibitor, for example, the lower PS2 or 3 patient?
Yeah, I mean, we, as you touched upon, initially it seems that these drugs were landscaped for patients with advanced and metastatic disease, which obviously can at times come with higher risks of a lower performance status. And you did find in the more phase 1 trials that patients of performance status of 2 were encouraged to go onto the trial. But as we got more knowledge to that, it became more a 0 to 1, 0 to 2 performance status essentially. Because actually, comparatively compared to chemotherapy, where these treatments are much more targeted, actually the side effect profile was less. So a patient who previously had chemotherapy, for example, may have had a very altruistic response to chemotherapy, felt very unwell, had lots of admissions to hospital, whereas the immune checkpoint inhibitors were actually offering patients much better quality of life, less need hospital admissions, etc. So actually that garnered that our performance status didn't have to necessarily be 0, but you could be treating up to 2 and 3 at points.
Okay, yeah, thank you. So I will, so performance status is very good factor for use of the ICIs, I think. So what is the contraindication to the ICIs of the patient?
So I think we would look again at performance status. We would look at any concomitant medications that they're taking. So if a patient was on high dose steroids, for example, because that can dampen the immune response, you wouldn't want a patient to be on high dose steroids before taking these inhibitors, primarily as it could reduce the impact that they can have on the tumour. Equally, things like if they've got active infection, etc., you wouldn't want them to be taking these therapies. Another contraindication is just that they can actually attend for the therapies as per schedule, because they are quite time-sensitive treatments, and you just want to ensure that you're doing the best by the patient by giving them in a timely approach.
So how about the biomarkers? So do you consider the biomarker to indicate the ICIs?
Yeah, so we would certainly look at the PD-L1 status, and if it was above 1, then we would consider treating with an immune checkpoint inhibitor. If it was below 1, then we wouldn't consider that, and would be quite honest with the patient about that. I think there's a lot in the media about immune checkpoint inhibitors at the moment, and when our patients are more informed than they ever have been in terms of access to the internet, access to publications, and a lot of our patients are seeing these as revolutionary drugs that are going to certainly improve, if not create cure for their tumours. And I think you just have to be very honest with them that actually if you don't have this mutation within your tumour, that actually this isn't the medication you should be taking. We'd be giving you unnecessary side effects for very, very limited benefit.
Okay, yeah. So it is a very it is needed to consider the biomarker to make a decision to think about the risk-benefit balance of the treatment. I think I agree. Thank you. So we sometimes experience the pseudo progression during the chemotherapy with the ICIs. And as you know, the pseudo progression is increasing the size of the tumor. So maybe the early stage of the beginning of the immune checkpoint inhibitors. No, but we should distinguish the pseudo progression to the real progression. So, Tara, so how do you distinguish the pseudo progression to the true progression?
Yeah, this can often be a difficult concept for patients to quantify, in that they've often been told if your disease is responding to treatment, then your disease will shrink. So actually the fact that they're told that their disease could get larger before it begins to decrease can actually be quite a difficult concept for them to understand. So I think it's important that patients are informed of that before they start treatment, just to give them a realistic expectation about what could occur. Pseudoprogression is generally accompanied with an improved general condition. So actually you find that patients are often feeling physically better. They may have improvement in their biomarkers, in their tumour markers, so like CEAs, for example, alongside their imaging. We often utilise the imaging and show the patient visually what's actually happening. So for example, on a PET scan, when you've got active disease, it can show up very bright, like a white light on the screen. And actually when they're responding to treatment, actually the white light can disperse, but you can still see the active outline of quite a large tumour. So it just shows them that the activity is less, but the tumour has just, this pseudo-progression has been causing the tumour as a consequence of the therapy. And I think it's just important that retrospective image analysis is also used, just showing them prior compared to now, especially as their treatment trajectory goes on, because generally patients are taking these treatment for as a minimum up to 24 months. So actually they can if they've got visuals of how things were and how they are now, actually that can help them ascertain actually what goes on with and how the tumours respond in this type of treatment. Where I did work in clinical trials, often biopsies were required on an ongoing basis. And patients are very responsive to that, to just know how their tumours were behaving. And that is useful, just although it's invasive, and liquid biopsies would be a great option in the future. It just can also differentiate whether tumour is still active or not.
So what is the proportion of the patient who experience pseudoproliferation? So that is depend on the cancer type. So Tara, do you have any experience for the pseudoproliferation? So
yeah, I would call upon more my head and neck experience, to be honest. There was a majority, I would say, would demonstrate pseudoprogression before they would show response. But generally, they mostly came with an improved general condition. So they all felt better. Their performance status was better, their ability to do things, their ability to go back to work, etc. Things that they weren't able to do before starting the medications was improved. But they themselves could feel that there was what they would describe as more pressure in the tumour. So especially where you've got them, like the tumours that would arise in the neck, and there's like a very limited movement of the skin in that, they would feel this swelling happening. But although they felt better, they could still feel this pressure, and they still felt like the tumour was growing, which is a difficult thing to quantify for them. So you'd kind of reach the 9-week mark post 3 cycles of treatment that you would do the imaging, and you'd notice the pseudoprogression, and then you do one a further 8 to 9 weeks later, and actually things had reduced. So yeah, it was quite notable in head and neck tumours especially.
yeah, okay, thank you for many helpful information. So it's not time to close this session. Okay, so thank you very much.
Thank you.
Hello, my name is Kato, from National Cancer Center Hospital, Tokyo. I am medical oncologist, especially for the upper GI cancers. Nice to meet you. So I am joined today by Mrs. Tara Hurley, an oncology nurse at the Royal Marsden NHS Foundation Trust in Sutton, UK. And I am also joined by Dr. Alison Palumbo, clinical oncology pharmacist at Oregon Health and Science University in Portland, Oregon, USA. In this session, we will discuss strategies for identifying and monitoring immune-related adverse events. So what common immune-related adverse events are associated with the treatment with ICI? So what do you check and to take care for the adverse event mostly for the patient using with ICIs, Dr. Alison?
Yeah, so typically when I'm thinking about educating a patient on taking an immune checkpoint inhibitor, often the types of side effects that we're looking for are things like diarrhea, rash, even like hepatotoxicity. And then one of the irreversible side effects that we see are the endocrinopathies. So things like thyroid issues, diabetes, that sort of thing. So those are usually what I'm counseling patients on.
Okay, thank you. So how about Tara? So is the same for you?
Yeah, I'd completely agree with Dr. Palumbo. We're looking a lot for like cutaneous GI, endocrine, respiratory, hematological side effects. Just doing a baseline assessment really of our patients and just seeing who may be more or less likely to develop side effects as they go along. As we're becoming more aware, somebody can be extremely fit and still develop these side effects. But I think if you've got a little bit of forewarning about somebody's predisposition, I think it can only stand to help. And again, just with communication about these things can happen to healthy participants. You can never have experienced these before, but these drugs do cause them. And it's just about being as open and as timely as possible in letting your clinicians know if you develop any of these side effects. So early intervention can be introduced to hopefully avoid it turning into something life-altering, potentially, or having to stop the medication.
Yeah, I agree with that. So the communication with the patient and the primary is very, very important to check the immune checkpoint inhibitor so to our. And so it is very, very important to control the IRAs and to continue the treatment successfully. So how the immune checkpoint inhibitors reflect to the patient outcomes. So how do you think about the correlation between the outcomes of the IRAEs? The Dr. Alison?
Yeah, so there actually was a meta-analysis done that was looking to see if these immune-related adverse events are associated with efficacy. And what they found is that, yes, like there does seem to be a correlation with these adverse events and efficacy. So particularly like endocrinopathies and rash, and even like, I think just having like a mild immune-related adverse event, these were actually associated with having better overall survival. So pretty interesting that, unfortunately, we don't want our patients to have side effects, but it does tend to predict outcomes a bit.
Yeah, so there's a many reports. The patient who suffered the IRAs achieve the long-term survival. So the IRA is a so-called on-target effect of the ICIs. So some patient with IRAs, but the severe adverse event with IRA so sometimes goes down the patient outcomes. So it is. We should check the IRAs more earlier and to control with them. So, Ms. Tara, so sometimes we should distinguish the similar adverse event by the chemotherapeutic drug or the immune checkpoint inhibitor. For example, the diarrhea is also occurred by the ICIs and some chemotherapeutic agent. How do we distinguish the similar symptoms by IRA or the chemotherapeutic agent? So how do you think about it?
I don't think you truly can. I think you have to assume it's related to the cancer in its entirety and manage the symptom as best you can. I think you've got to remember your fundamentals of clinical care and just not assuming that it's related to the drug. That you do, like if it was diarrhea, for example, sending microanalysis of the stool sample, seeing if you interrupt the drug, does that improve the diarrhea? That would go for a chemotherapy or an immune checkpoint inhibitor. And I think you just have to do your best clinical build-up to actually ascertain what is the cause of this, because it would be a terrible shame to stop treatment for something that was actually maybe even related to something that they ate at a restaurant that's caused them to have an upset tummy.
Okay, yeah, thanks. So sometimes it is difficult to distinguish any symptoms. So how about this? So do you have any concern about that? So Dr. Alison?
Yeah, I would agree. Definitely being mindful of different causes of these issues. So for instance, oftentimes looking at hepatotoxicity as an immune-related adverse event, it's sort of a diagnosis of exclusion. Like you need to make sure that you've ruled out disease progression or maybe viral hepatitis or some other cause before you attribute it to immunotherapy. And I think, this is definitely an excellent question because we are seeing a lot more combination regimens coming out, combination with chemo, combination with VEGF inhibitors. So there are different tactics to sort of figuring out if we think it might be from one drug or the other. So for instance, combination with VEGF inhibitors, there's very explicit instructions on trying to figure out, is it the VEGF inhibitor or is it the immune checkpoint inhibitor? And again, a lot of times it's very murky. So just trying to be, again, like Tara mentioned, being very mindful of this and using your best clinical judgment is going to go far.
Yeah, so firstly, we can use the monotherapy with ICIs, but recently the many combination therapy, chemotherapy with ICI and ICI with ICI and ICI and the target therapy. So it is more complicated, and so we need more information about that. So okay. So finally, do you have any point to predict the IRAs? So before starting the treatment, so what is the risk factor of the IRAs for each patient? So Tara, so do you have any checkpoint to the risk of the IRA?
Yeah, I mean, I think we look at the demographics and social history of the patient, medical history, medication history, any tumor-specific and agent-specific risk factors that may be involved. I know there's a higher risk of immune adverse events associated with people who are less than 60 with a higher body mass index, women who are on CTLA4 agents, and men who are on PD-1 agents and could be more susceptible. Chronic smokers can have precursors to having more likely risks of immune-mediated adverse events. And then just looking at things like their cardiac histories, if they've ever had any fibrosis of the lungs, etc. All of those are precursors to thinking that someone maybe have a potentially more predispositioned. But as we've touched upon, immune-related adverse events can be quite silent. So there's things that you can't know, and it's only by doing blood testing, etc., that you can ascertain if they're having hematological or biochemical untoward responses. So it's about using both your practical sense, the process of elimination, but also using medical science to support your diagnoses and getting your differentials of what's actually happening.
Okay. Thank you for the very helpful and informative talk, Tara and Dr. Alison. Okay, so it's time to close this session. Okay, thank you very much.
Thank you. Thank you.
Hello, my name is Kato. I'm a medical oncologist for the GI cancer. So I'm from the National Cancer Center Hospital, Tokyo. I'm joined today by Ms. Tara Hurley, an oncology nurse at the Royal Marsden NHS Foundation Trust in Sutton, UK. I'm also joined by Alison, Palumbo, clinical oncology pharmacist at Oregon Health and Science University in Portland, Oregon, USA. In this session, we will consider approaches for management immune-related adverse events. Tara, could you present your cases? Could you please?
Yes, thank you, Prof. Kato. So my case study refers to a 61-year-old male who had a diagnosis of metastatic head and neck cancer. He was treated with durvalumab within a clinical trial, and he commenced that in April 2022. he was doing extremely well on therapy in terms of his performance status had improved. It afforded him the ability to go back to work, which he very much enjoyed. And he had really good quality time with his family, managed to go on holidays, etc. This was amplified by a good partial response on a CT scan in July 2022, which just exemplified actually this was a really positive treatment experience for him. However, in August 2022, after 6 cycles, this gentleman was found in a routine clinic appointment following blood tests to have liver and hematological toxicity. The main issue surrounding that was that he had a grade 2 ALT increase, which is more than 3 times the upper limit of normal. And although he didn't meet Hy's law criteria as per trial protocol, we had to interrupt the treatment to get this to resolve to grade 1 or baseline. Despite the interruption, unfortunately, we interrupted for 4 days. The liver function didn't actually improve, and it actually worsened somewhat in that the bilirubin levels began to increase also. So the patient was started on a dose of 100 milligrams of prednisolone, along with some lansoprazole, which was for gastric cover, given the high dose of steroids that the patient was on. 2 days post-commencement of this, actually, his ALT had reduced down to grade 1, so we were feeling really positive about the improvement that had been made. And we began to titrate down in 25 milligram increments. However, when we did our first increment reduction, and 2 days after that we tested his bloods, unfortunately, he went back to the grade 2 ALT, which made us feel a little bit despondent actually about what was going on for the patient. So we consulted our MDT colleagues, namely the former hepatologist, who recommended the introduction and conversion from oral prednisolone to IV methylprednisolone. And the patient took this for 7 days. Again, a noted improvement was seen, and they aimed to titrate back to an oral dose of prednisolone along with lansoprazole cover. But unfortunately, the patient kept having this seesaw effect in that we could never get them back to a baseline recording. And unfortunately, due to the trial protocol and the length of time that the patient was off therapy, the decision was made a couple of months after to discontinue the patient from the drug, which they were obviously very disappointed about. It was also to be noted, because of the high dose of steroids that the patient was taking, that they also developed medication-induced diabetes. So they also developed a subsequent comorbidity along with this. So I think in summary of this case, it just demonstrates that actually a patient could be having a really positive response to therapy, but unfortunately the indolent and unknown side effects with immune checkpoint inhibitors that can often just be found by routine testing do occur, and actually they can be quite difficult to manage even if you've caught them early. So I think actually it just lends itself to the fact that immune checkpoint inhibitors, although they are a brilliant drug and very effective, actually the side effect profile isn't to be undermined or misunderstood.
Okay, thank you. So, so how do you discuss to treat IRAs? So, they decided the cases. So, what kind of the communication with another? So you mean the hepatologist or oncologist or another specialist?
So the site we were working at wasn't a general hospital, it was a specialist oncology centre. So actually we didn't have readily available resources to assess the patient. So we had to call on our allies from external centres. And we contacted the hepatologist because it seemed that despite the standard treatment that namely works in these settings, i.e. oral prednisolone, oral steroids, actually when we were trying to titrate that down, it wasn't working for the patient. So we had to seek specialist advice. And that's when they recommended the IV methylprednisolone. Again, for this patient being on a clinical trial, they travelled significant distance to come to the hospital for this treatment. And actually attending for methylpred, we had to liaise with a local hospital to get that done on a daily basis for him. So it's just about having knowledge of your MDT that are in your hospital, but also in the surrounding areas that can support you and the patient to get effective treatment and management as soon as possible to avoid the issue escalating beyond what it already is.
Okay, yeah, but I think the early communication is very, very important, I think. So, and so, Dr. Alison, so if the steroid does not work for the control the liver dysfunction by the immune checkpoint inhibitor, how do you use and manage for the patient the liver dysfunction? So, is there any other treatment procedure by another immunosuppressive enzyme?
Yeah, that's a great question. So generally, for immune checkpoint inhibitors in general, we tend to consider someone sort of steroid refractory if they haven't improved on steroids after 2 to 3 days. So it sounds like maybe this patient was improving, but then they had sort of a relapse in their symptoms. So I don't know if they were quite steroid refractory, but if there was someone who was steroid refractory with liver toxicity, when you think of agents to use in the steroid refractory setting for immune checkpoint inhibitors and their adverse events, a lot of times the first drugs that come to mind are like infliximab. But it's very important to remember, in liver toxicity specifically, you don't want to use infliximab because it can potentially worsen the liver dysfunction. So specifically for liver toxicity, you don't want to use infliximab, but you could use some other immune suppressive agents, so things like mycophenolates, even tacrolimus, other agents that have immune suppressive properties.
Okay, thank you. So one more question I have. So if the patients recovered IRAs, so after the prednisolone, the tapering, so do you think about the challenge of the immune checkpoint inhibitor for the patient if the patient the tumor regrowing after the stopping the ICIs? So, Dr. Alison?
Yeah, it really depends on the situation. So guidelines definitely have recommendations for when you should permanently stop therapy. So definitely follow those recommendations. When I say guidelines, I'm generally referring to like NCC and ASCO. That's what we use in the United States. There might be other guidelines elsewhere, but that's typically what we're using, and certainly follow the package insert as well. One thing I did want to mention, just to bring it up, because I hadn't mentioned it yet, is when you're giving someone long-term steroids like this, like over at least a month, more than a month, and at least a dose of prednisone 20 milligram equivalents daily, you want to make sure that you are also providing them with some sort of PJP or pneumocystis prophylaxis. So that's something else I wanted to mention.
Okay. Yeah, it is very, very complicated. So it is a very, very difficult to decide. So yeah, of course, I think it does depend on the situation and the patient condition and willingness. So, and if we have another choice, for example, the chemotherapy, so it is better to use the chemotherapy rather than the ICIs. So, okay. So, thank you for the very helpful information. It's time to close this conversation. Okay. Thank you so much, Tara and Alison. Thank you so much.
Thank you. Thank you.
Hello, my name is Professor Kato from National Cancer Center Hospital, Tokyo. I'm a medical oncologist, especially for the upper GI cancer. So I am joined today by Professor Albrecht Stenzinger, a pathologist at the University Hospital Heidelberg in Heidelberg, Germany. In this section, we will discuss the role of biomarkers in informing the use of immune checkpoint inhibitors across tumor types. So we can see some biomarkers for the immune checkpoint inhibitors, and the many of the biomarker was reported day by day. So I would like to ask Professor Stenzinger, so what the companion diagnosis are available to guide the treatment decisions for patients with such tumors right now?
Thank you. That's a great question. So currently, if you look at the clinical landscape and look at what has been approved over the last couple of years, you can probably separate, two big parts. One are pan-cancer biomarkers like tumor mutational burden, TMB testing, and the other is microsatellite instability. Both are genomic biomarkers where you are inferring or interrogating a specific, genomic status of the tumor cell, and that allows you to identify patients who might respond to a certain type of treatment. And the other, non-pan-cancer biomarker is PD-L1 immunohistochemistry. And there we have different indications, different tumor types, where PD-L1 immunohistochemistry can be used to predict response to checkpoint blockade. And importantly, you can probably separate different scoring approaches that have been introduced by the approved trials. So the tumor proportion score, for example, then looking at tumor cell expression only, looking at immune cell expression only, and looking at the combined positive score. All of these 4 different scores are being used in different indications for different tumor types, as I said before, and depending on thresholds from these clinical trials, patients are either eligible or non-eligible for checkpoint blockade.
Yeah, thank you. So TMB high and MSI and the PD-1 status is used for the clinical practice right now. But the Professor Stenzinger mentioned, and there's many threshold of the PD-1 status percent, and many of the procedure to make the PD-1 status. So one more question I have. So there is many the procedure. For example, the TPS, tumor proportion score, and CPS, and then so many antibody is exist. How do you use the biomarkers in the clinical practice?
Yeah, that's another great point. There are several immunohistochemical antibodies, as you are mentioning, which have been approved alongside the respective clinical trials, and that obviously expands the complexity, because it's not only about different scoring systems and different thresholds for different lines of therapy and different tumor types, but also different immunohistochemical antibodies currently being used. And there are mainly 2 approaches to that. So there are institutions worldwide who really are using different immunohistochemical antibodies for the various indications, and others decided to stick to one antibody. There are a lot of harmonization studies that have been conducted and are still being conducted, trying to or aiming at comparing the performance of the different immunohistochemical antibodies, and so that can give you a hint or help you in implementing your immunohistochemical test in a clinical setting. We usually provide all of the scores regardless of the tumor type, so that the oncologist who is seeing the report can decide based on clinical knowledge which of these scores might be appropriate in that specific indication, but that might vary again from center to center. For microsatellite instability, we are using 3 tests. So one is immunohistochemistry, interrogating the 4 DNA mismatch repair proteins. As I said, by immunohistochemistry. The other is a PCR-based test where you're looking at certain microsatellites and whether their length is being altered. And the third test that you can use, but is next-generation sequencing, a targeted sequencing approach where sufficient numbers of these microsatellites are covered, and that similar to a PCR-based approach, can allow you to identify microsatellite instability high cases. Of note, all of these tests need to be validated prior to its use, just as with PD-L1 immunohistochemistry, and obviously the same holds true for tumor mutational burden TMB testing, where you also need to have a validated test to run in your lab.
If we use the biomarker to the clinical practice, what kind of the validation is needed to the another new biomarker?
Thank you. Yeah, as you are saying, there are many biomarkers being reported in the scientific literature almost every day, ranging from cytokines, cytokine networks, interleukins, tumor infiltrating lymphocytes, spatial distribution of specific lymphocyte populations, even the microbiome has been reported to be of use here. Importantly, all of these are really at a preclinical stage, meaning that they have been investigated, for example, in retrospective registry-based studies or in model systems. Maybe sometimes analyzed alongside clinical trials prospectively in a separate biomarker arm, but they are not approved for clinics yet. And I think the most important part is that there is clinical utility, obviously, and that can only be shown by a prospective clinical trial with a predefined outcome. It is also important that such a biomarker is significantly better than the other ones that have been discussed by us before already, to be a meaningful complementary tool to the other biomarkers. And I think one of the most challenging points is probably the enormous complexity of the tumor immune cell interaction or tumor immune system interaction, with many different cell types being involved, the spatial distribution of these cells, the HLA haplotype that plays a role here, and probably we haven't understood biology sufficiently yet to really come up with something that is adequately covering the complexity of this kind of interaction. And then if it is very complex, you always have to think about how can you eventually translate that in a routine diagnostic test that has a broad diagnostic outreach, meaning that it can be used by many institutions, so that many patients are being tested.
Yeah, I totally agree with you. So I'm very interested in the microbiome, but it is very, very difficult to examine to correct the fakers, and the faker examination is very difficult to adopt the clinical practice. I think so. Okay, so some convenience and the clinical adaptation is very important. I think so. Thank you for your information. Okay. It is time to close this session. So thank you, Professor Stenzinger, for the very helpful and informative talk for us. Thank you very much.
Thank you.